Hi, my name is Aubrey Frazzitta for those who don't already know me. I'm a third-year radiology resident applying for neuroradiology fellowship this year. Thank you to the DMI Research Day Committee and my mentors for this opportunity to speak. Today I'll be presenting a case of Bow-Hunter syndrome in a pediatric patient. I have no disclosures. Bow-Hunter syndrome, or rotational vertebrobasilar insufficiency, was originally described in 1978 by Sorensen after a gentleman presented with suspected brainstem infarct. He had sustained an injury during bow hunting. Periodic and reversible occlusion of the vertebral artery is seen due to neck rotation. This is a rare cause of posterior fossa infarcts in young children and adolescents, with approximately 26 cases described in the literature. There is often an underlying bony or fibrous structure, such as an arcuate foramen, which tethers the vertebral artery, resulting in compromised distal flow or vessel wall injury with eventual thromboembolism. Our patient is a 2-year-old male with no significant past medical history who presented with intermittent dizziness and vomiting. Axial DWI image demonstrates an acute infarct within the left cerebellum. Unfortunately, 3 months later, the patient presented again with dizziness. He was found to have a recurrent posterior fossa infarct within the right superior cerebellum, with restricted diffusion and minimal T2 hyperintensity. The remote infarct from 3 months prior is also evident within the left cerebellum. Frontal DSA image during a right vertebral artery injection demonstrates irregularity of the distal cervical right vertebral artery. The same finding is also seen on MRA time of flight image. This companion case demonstrates an additional example of Bow-Hunter syndrome. Axial DWI and ADC images demonstrate an acute infarct within the right cerebellum. For this patient, dynamic imaging was also performed. This DSA image in the neutral position demonstrates normal caliber of the vertebral artery. When the patient's head was rotated rightward, left vertebral artery irregularity was seen. The same finding is also seen on the opposite side. This is a side-by-side comparison demonstrating neutral versus rotated head positioning, again showing transient positional vertebral artery caliber irregularity. Tightly windowed reconstructed image from the DSA shows the same findings. Diagnosis of Bow-Hunters is made challenging due to the dynamic and reversible nature of vertebral artery occlusion, especially in the absence of a discrete dissection. Imaging evaluation can be performed with vascular ultrasound, CTA, MRA, or DSA. The preferred method of diagnosis is DSA, which allows for real-time neck rotational maneuvers to evaluate for vessel compression or occlusion. Both vertebral arteries can also be evaluated simultaneously. On CTA and MRA, radiologists should pay close attention in regions of bony and fibrous anomalies, particularly at the C1-C2 disc level. Treatment is directed to correct the underlying abnormality, but generally includes decompression and fusion. Due to the rarity of this syndrome, especially in pediatric patients, there is insufficient data to reach consensus on management for this devastating syndrome. Here are my references. And thank you very much.